So, good afternoon, everyone. I'm Alexander Alonso, General Manager for BD Benelux, and on behalf of my 1,200 colleagues, I would like to welcome you all to this session in a very petit comité, what was on purpose, but it got a bit smaller due to some illnesses. We should have invested a bit more in prevention, I believe. First of all, on a personal note, I would like to wish you all the best for this 2025. I'm still on time. And like we say in Spain, I wish you all a lot of free time to enjoy your money, your good health with your beloved ones. Now, before we go into a very interactive session that needs to focus on solutions, I would like to do a little introduction on who BD is, why we are here today, and some ins and outs about how the barometer, the resilience barometer, has been gotten together. First of all, tell you that BD is one of the largest medical technology companies worldwide, with more than 77,000 associates around the globe and active in almost 200 countries. Now, important to say is we invest year on year more than 1 billion into research, development, innovation and acquisitions to be at the forefront and impact healthcare, advancing the world of health. If we look to Belgium, we are already a bit more than 60 years active in Belgium, let's say Benelux, as we are a Benelux organization, with around 1,200 associates, 57 plus nationalities. I can tell you 59 since last week. So a very diverse organization with a 50-50 female male, and where 1/3 is younger than 30 years old. So inclusion and diversity is very important for us. They're all spread across 6 sites, where the diversity of the productivity, the activities of the site is very clear. We have a site focusing on research, development, production of lab automation. We have our logistic campus where all the corners of the EMEA region are being supplied with BD products from Belgium. And then we have a very big commercial hub and then a very small one in Luxembourg. Now, our impact to healthcare is very wide. And I always say I cannot imagine anyone walking around in Belgium that haven't been in touch with BD, even being a newborn. Our reach is super wide, and we start from supporting research centers, industry, universities in their research to better understand certain illnesses and also help them to support with therapies. Secondly, in the medical part, we talk about providing care, and you can think about syringes, needles, catheters, but also a lot of robotics and software that will provide and support a much efficient and safe way of managing medication. Also on the interventional side, we're very active, where you can think about stents, but also about temperature control management systems to bring down the temperature of patients to prevent vital organs to fail. Last but not least, we move into the diagnosis, where you can think about blood withdrawal, but also we can design and help customers to really build almost fully automated diagnosis lab. And we are growing. As we speak today, we are integrating our latest acquisition, that is the critical care piece of Edwards, that we will call it APM, Advanced Patient Monitoring, and you will find more about it in the coming weeks and months. Now, we are here for one question, and I would like to make it very personal, thinking of my son of 11. Will he be able to access the quality of care that we are used to or we were used to? And that may be the question of the day. Are we able to provide the right technologies? Are we able to invest in the right innovation? Will be a country like Belgium able to finance the healthcare we need in the future? And that's what it's all about. And there are two topics that really need to remain at the forefront when we discuss this. One is the sustainability. It's about the accessibility to care. Are we able to pay the care? Is the outcome qualitatively right? Are patients getting the right therapy at the right time, at the right cost? And second one is resilience. And resilience links more to, like in COVID, if a crisis arises, how resilient are we to adapt to that, to provide an answer in a very fast way? Thinking about those two, out of the Barometer, we have highlighted 3 themes that are the main themes that cover almost every answer or every solution to that question. And the first one is related to patients and think about patient safety. Second one is like how supporting the healthcare workers. And the third one is how to make processes in healthcare more efficient, to be faster, accurate, and avoid errors, and so making even savings. Now, why do we do this effort? And this morning, a few journalists came to me asking, well, company as BD, why are you investing in this? And I have to say, we take our responsibility. And there's a lot of data that is possible to look into. We have really, since 2023, looked to build a kind of a resilience barometer where 22 different aspects are listed up. And to give a score, to also rank, but for sure to really understand what are the challenges out there and think in terms of solutions. We want to take our responsibility and put this on the table to have a dialogue. And also for us to better understand what are the trends, challenges of the future, where we as BD could also provide answers. Now, as I said, the Healthcare Resilience Barometer is a comprehensive analysis that we have been conducting since 2023. It explores the resilience of healthcare, and we do it across 100 countries in EMEA. There are 22 indicators based on primary literature and secondary data sets, but also based on KOL interviews and perspectives from experts out there. This provides you at the end, on one hand, a ranking, and then you can think what would be the ranking of Belgium in that set of 100 countries. But it also provides you a resilience score. And you can go deep to see what are the things we are really doing very well, but what are the opportunities to do much better. The theme of 2024 is really linked to the 3 topics I already mentioned: the patients, healthcare workers, and the healthcare and the efficiency in processes. So today, what we want is to sit next to each other, looking in the same direction, to join forces and find solutions. I think this is what this panel is going to be about, to look at solutions. And I hope, and on a personal note, what I think is needed is some real empowerment, governmental, political, to bring what we already all know, what experts are already providing as solutions, but to bring them into action and to the next level. With this, I would like to hand over to Cynthia, that will be our moderator today, and wish you a lot of luck and make it as interactive as possible. I'm looking forward to the answers.
Okay, thank you very much, Mr. Alonso, for this great introduction. Ladies and gentlemen, good afternoon and welcome. As Mr. Alonso said, my name is Cynthia Reekmans, and I will be your host for this hopefully very interesting roundtable discussion this afternoon. And first of all, I would like to thank you for joining us. And our goal today is not to dive into the results of the Barometer in detail. No, we are going to use some of the key findings to have an open, interactive discussion, not only with the panelists, but also with you, the audience. And the focus, the mission, is to find some solutions to build a better, resilient and sustainable healthcare system in Belgium for the current and future generation. We have built today's discussion flow around the three topics, the three pillars of the BD Healthcare Resilience Barometer: the patients, the healthcare workers, and the efficiency of the healthcare system in our country. And so we would like to make it very interactive, so please keep your phone at hand to scan a few QR codes when your input will be requested, and be ready to speak up and to make your voice heard. But first, I would like to welcome and present the panelists of today. First of all, I have Dr. Bart de Mietenare. He is currently Director of Policies and Studies at Solidaris, the second biggest healthcare fund in Belgium. And together with a team of 18 high-leveled, high-qualified employees, he determines the policy alliance of Solidaris in cooperation with the general management. He is active in multiple consultative bodies at NIHCI, specialized in public health, juridic patient advocacy, nomenclature and its reform, hospital financing, new technologies, and mobile healthcare solutions. A lot. Welcome, Dr. de Mietenare. Next, we have Dr. Sebastian Matthew Spencer. He is Chief Medical Officer at Europe Hospitals. And Dr. Spencer has a rich background in hospital administration and has been instrumental in introducing efficiency improvements and fostering collaboration within and beyond the hospital walls. Welcome, Dr. Spencer. And we also welcome Rudy Maartens. He is a CEO and General Director of AZ Alma, where he leads with a strong focus on people-centric initiatives. Under his leadership, AZ Alma emphasizes personalized care and the well-being of both patients and staff. His commitment to fostering a supportive and innovative environment has made a significant impact on the organization's success and growth. Welcome to you all, gentlemen. So you have all had the chance to read the Barometer, the report. So my first question to you all, what were or what are your key takeaways, and were there any surprises for you? Dr. de Mietenare, let's start with you.
My first surprise is that we were only 35th on the ranking. And I had anticipated that we would still be a little bit higher than 35th. So I think we have a good system. You can discuss if we have a very good system on certain levels, maybe yes, but I think there's a big room for improvement. And for some aspects, we score very, very low, lower than I had anticipated. So I think there's a lot of work to be done.
Okay. Dr. Spencer, what are your highlights?
Yeah, I was in a state of shock when I realized we were so low.
Yeah.
I think we were used at one point, long time ago, to be in the top 10 and then in the top 20, looking at various rankings. So 35th position was a shock. And I said, okay, how can we transform this state of shock into positive energy and say, okay, in the next iteration, we want to see an improvement compared to where we are today. And I think that's the most important, because when looking at all the different indicators, okay, this mix of indicators brought us to the 35th place. Okay, how can we change that and make sure that next year we see improvement, and the next. It takes time to see improvement. So maybe not next year, maybe later.
Okay. And Mr. Maartens, what are your key takeaways from the report?
Maybe first of all, I would like to stress that in general, the whole world has approximately the same problems, creating a good healthcare system. So I was not so very surprised about the different accents in the report. Behalf one, the healthcare-acquired infections, 9.2.
Yeah.
Wow, that's one out of 10 patients. We are giving extra problems to. We are wasting money and time and good care. I think that's high. So that was astonishing for me.
Yeah, we will come back on that point later also, but we are a select group today, and we also want to ask you, ladies and gentlemen, for your opinion. So it's time to take your smartphones and to scan the QR code, and then you can choose from the provided list 3 topics, 3 burning issues that you think are the most relevant ones. So please take your phone, scan the QR code, and then you can indicate which do you believe are the 3 most burning issues today. So we see, and you can follow on the screens as well, that 24% is indicating an inadequate funding system, not incentivizing the quality. Dr. De Mittenare, what do you think about this issue on top?
Yeah, a little bit surprised that it's top, but it's a very important issue. And I think everybody agrees that we should put our financing more in quality than in volumes. And I think it's a correct statement. So yes, I can agree with what the public says.
Yeah. And then on the second place, 18%, we have the quality of care, the burnout, stress, the work pressure, and the focus on prevention. Dr. Spencer, you understand why?
Yeah. So I'm happy about the result, and so we can talk a lot about funding and what is it we do already today to incentivize quality within our hospitals, because there are initiatives, but there would be many more if the funding system was different. Variability of care is a great concern, and the incentive to collaborate within networks or with other hospitals isn't always there to make it happen, so that we can decrease the variability. And the high burnout stress, this is our day-to-day issue at hospital level.
Yeah, okay. But what is striking is that although Belgium lags behind major European countries in patient safety with the 35th place and the rate, what Mr. Martens was telling, of 9.2% of patients in Belgian hospitals acquiring a healthy care-associated infection, this doesn't seem the top burning issue, Dr. De Mittenare.
I think we don't talk about it enough. And I think we don't talk about it enough in public. I think we need good data, good registration, and also a more public presentation of quality of care, of incidents. We are afraid of blaming and shaming, and we should talk more about incidents. There are a lot of incidents that happens because sometimes it's not a system that's not that negligent or so, but we lack communication about it, talking about it, and trying to learn the lessons from incidents to avoid them in the future. And we should do also much more on prevention of incidents.
Yeah. Do you agree, Dr. Spencer?
Yeah, I agree, absolutely. Would we have also a better platform for collaboration within networks? This is something we could do. It's true that we're not speaking about it enough, and transparency isn't there, and people are afraid of transparency. It's true, and at hospital level and leadership level also. So how can we break the ice and start talking about it? So with regard to what we could do, just the P for performance today within the financing is very small. It's a very small proportion. But within that small proportion, for example, we have this system where when the financing for the fee-for-service care comes to the hospital, that a small percentage is being left aside and redistributed to doctors according to achieving quality targets. The quality targets for 2025 have been determined as working on the standardized mortality rate HSMR, and working also on decreasing the use of antibiotics within the hospital. So, and it's a gross measurement, so the number of days of antibiotics given in total at the end of the year per unit. But we believe it will work. When we have used these percentages that are left aside on other targets, the previous year it does work. For example, one was about filling in properly the electronic medical records, and that was associated with this 1% going back to the medical community, and that worked. So would there be more about quality? I think it would have an impact.
Yeah, Mr. Martens.
When I see these results, they are not very surprising, because if you see the top 3, these are the short-term problems we are facing today.
Yeah.
But my message is we should connect different of those topics, because the long-term solution is in the integration of care and is in connecting quality to funding models. So follow the money, and if you create value and you have a value-based healthcare system as a system, not paying per service or fee for service anymore, then you're creating a solution for the long run, in the long term. So it's normal that everybody who's filling out this questionnaire is going to point the short term, the today problems we are facing.
Yeah.
But we should think further on,
how
and
we can resolve.
trying to create a system which will be sustainable for the long term.
And is there a solution, or
It's a complex complex question, and there's a lot of work to do.
Yeah.
But I'm a believer of integration of care,
Okay.
and that's the only way we will solve the big problem we have. If you have one strategy, one vision, one leadership, and so one volume of money into that integrated care system or circuit or network, which should be regional.
Okay. Now, coming back on the infections and the HIAs, if 50% of these incidents are avoidable, Dr. Spencer, what should we need to do to avoid them then?
We talked about the transparency, and that's probably an important step. The 9.2% of hospital-acquired infection per admission is gigantic. I hardly could believe it, but okay, we take the numbers for what they are, and also to work together. But if I take the network system in Belgium, in many networks, hospitals are competing with each other, and there isn't a common governance. And so without common governance, with competing interest, doing something together like hospital hygiene and the HOST project from the Babcock that is still running today, but with many problems in many networks. It shows the limitation of networks. So how can the system promote collaboration as opposed to saying, okay, if we collaborate, what is it we're going to lose? Because as far as I'm concerned, I have a community of doctors, I have employees, nurses, logistic, administration, and they trust us to make sure that we as a company will survive. So when we go into collaboration and when the finances are so tight, then we look at what is it we're going to lose? What is it we're going to gain? So how can we leave this system so that we can engage in collaboration, not being in fear of what we're going to lose?
You agree, Dr. Mittenaren?
I agree, and I think we have to change the culture and convince people that talking about things that are not going well, incidents and things like that, are better for everybody.
Yeah.
And now we're too afraid of losing, and that's, I think, a shift we need in the near future.
Yeah. Okay, thank you. So another question for you, dear audience, is what do you think needs to happen to lower the healthcare-associated infections? Do you have any examples to share? Maybe you have already something that you're doing in the hospital or in the institution that you're working in. So you can answer this question out loud. So if you want to say something or to give a remark, we have someone who can hand over a microphone. You would like to...
Wash your hands.
Raise your hands, yeah.
Wash your hands, yeah.
Oh, wash your hands. Okay, yeah, of course, yeah.
Are there regional differences in this figure? 9.2 is a Belgian figure. Do we have any idea of this type of...
Do we know
I
that?
have to look to the people of BD. Apparently not.
No, it's for all Belgium.
In a lot of cases, there is a perception that in the southern part of Belgium, it's worse. But research indicates that this is not the case, that it's quite general.
Yeah, Hans, but shouldn't we put the question on sort of ranking of hospitals and say those few hospitals on top who take the number a little bit higher or not? Just open question. Because now we know it's Belgium, but we can't mobilize all the Belgians to change this. We have to go and search where is the biggest problem and where do we have to tackle it, I think.
Underlying, I was just wondering if it has to do with culture in society, whether the fact that you have more infections has to do with the general attitude of people towards
Hygiene.
healthcare or towards education in healthcare, which apparently can make a difference.
Yeah, you can give the microphone.
I understand what you're looking for. On the other hand, if you compare this to the average in Europe, this is already astonishing. So
yes.
We can keep discussing about on one side of Belgium or the other, but already the average is really very bad. What I think is an extra to this is that the half of those are avoidable. And I think that's where we need to focus on how to avoid them. Because again, this brings extra pressure on an already pressured healthcare system and healthcare workers, extra costs. Those people also have complications. They don't return to work. In my case, leading a company, I need to then look for... So it's a vicious circle that this one infection gives. And if it's avoidable, I think we need to look at how to avoid it.
Yeah. Okay. Dr. Spencer, you would like to add something?
The culture of how we perceive hospital hygiene in Belgium is also fairly negative. We opened a position for a new hospital hygiene doctor 9 months ago. It took us 9 months to identify one candidate. Not that this is going to be a recruitment, but it is a candidate, at least. We have heard a lot of people who have the qualification. A lot of microbiologists have the qualification. They do not do it because they want to become specialists in hospital hygiene. They do it as a complement, as a microbiologist. But when you approach them and you say, would you want to come and work with us? They say, oh, hospital hygiene, never. They're not well considered by clinicians within hospital. They give extra workload to the nurses in a unit whenever they come. So the perception of hospital hygiene is very negative. There is a change of name to try to sort out the issue, moving to infection prevention and control rather than hospital hygiene. But in our culture, it's not, people don't like to talk about it, they don't want to do it. So there is something that we can do.
See it as a burden.
Yeah.
Yes. And is it different in other countries where there is another image of it? I don't know.
Yes.
Maybe we can learn some lessons.
Yeah.
It's good to have someone to take care of hygiene, like someone to take care of security or filling up checklists, whatever. But what do you think about if you were to lose like 10% of your funding because of these results? Would things change? I mean, for the hospital, also for doctors. I mean, if we were like really challenged by this quality outcomes that would affect our
Yeah.
funding. Do you think that would be a solution?
Immediately.
Do you agree? So financing is a huge tool.
I think so too.
Yeah.
Okay, good. Thank you. So we heard saying, Dr. De Middenare, that more registration and monitoring could help bring down also the infections, but that could increase the already high burden on staff. So this brings us seamlessly to our second topic of this discussion, the healthcare workers. So, Mr. Martens, what do you see as solutions to reduce the overall burden for the care staff?
Well, first of all, I think there's no one solution fits all. I think we need a multi-level approach, and I will give you 5 examples where I think each of them can work. First of all, I'm convinced that we should increase the knowledge in each care organization about lean management. Mm-hmm. It was invented in the car industry, okay, but I'm really convinced that if we should increase that kind of knowledge, we learn to look at our processes, we learn to analyze processes, and we learn to see where there are the not added value actions we are taking day to day, every day, and everybody. But this is a certain way of looking at things, at business processes, and once you have those kind of skills implemented in your organization, then on a natural way of behavior, you will learn to reduce waste, to reduce variability, to reduce waiting times, etc. And so if you know the non-added value actions and you cut them out of the process, then you are redesigning your business processes, and immediately you will see the effect on that. Mm-hmm. The workload, the perceived workload will reduce, the flow will increase, and you can take care for more patients with the same or less resources. So I'm really convinced on that, but at the same time, I'm astonished that the adoption of lean management translated to the care process goes so slow. My second example is giving much more autonomy for the care professionals mm-hmm. in making their own organizational schedules, the shifts they have to do, but also give them some autonomy in rethinking their tasks and try to be innovative, because I really think that this can improve the work-life balance. I'll give you a third example. When you have the luxury, and I had that luxury, to create a totally brand new hospital, yeah. Then you should be convinced that we have the task to design an intelligent hospital, an intelligent building, using state-of-the-art technology, which is there. There is a technology enough, mm-hmm. but we should learn to use it. And if you do the right design of your building, then, that's my experience, you can shorten walking distances. Yep. Every walking distance is a waste of care time. Yep. If, for example, you implement certain RFID systems to detect ordering of usables, material nurses and doctors need to take care, you can simplify those logistic processes enormously. Again, the result is you create care time instead of administration time and so on. Mm-hmm. My fourth solution is IT, digital solutions, and AI. Yep. Again, we should use AI and IT in a smart way. Every action which is repetitive is a stupid action. To use high qualified care professionals to fill out forms, etc., etc. And there are innovations. This week even, I was meeting with an MD, a medical doctor, who created a startup. And his innovation is that patients in the emergency room, they can talk to an app, and this app translates immediately with a high rate of security what the symptoms and the clinical situation of the patient is. But there's a hell of a problem that that kind of data cannot enter the electronic patient record. So we have wonderful startups in Belgium with wonderful innovative ideas, which are very difficult to implement.
Yeah.
My last one is use data. We have a lot of data, but we don't use them enough. And if we would use data, analyze data, trying to create prediction models, then we can predict which kind of patient in what kind of volume will enter our hospital. So 5 totally different solutions I have chosen.
Yeah.
If we try to implement that in real life, then we will already do a little bit of the solving a little bit of the problem.
Yeah, but that is what we see in the results of the barometer, that the implementation of the innovations goes too slow or is too slow at the moment. Huh? Dr. De Minter, you would like to add something?
Because you started with registering, I think it's crucial, it's very important. The thing is, how can we do it in a smart way? I follow the principles of only once. Now today it's not only once, it's only 10 or 20 times the same thing. And the second thing is, if you put garbage in, you get garbage out. And the thing is, we've got a lot of data. I think we have an overload of data, but they're all in different places, not talking to each other. We come again to communication. Data should also talk to each other. And we've got the tools. We've got artificial intelligence. We have to integrate all those data, and then we can do a lot of things and relieve the burden of many caregivers, not by taking away the registration, because a professional caregiver has a role in putting in data. But if he can put it in his electronic file once, and that all the rest is back office, I think we can do a lot for the burden of work on caregivers.
Yeah, Dr. Spencer, do you see any possible solutions or things that could be?
What you said nicely connects with the efficiency pillar, if I may. Because lack of efficiency is killing motivation of people, and that's exactly what you say. We also need transparency within a hospital structure. Not later than last week, a colleague who recently joined the medical direction at Europe Hospital wanted to do Gemba walks, to go to units and have a look and meet the people. And I say, okay, go. But please make sure that you inform some of the people within the nursing structure so that they're not surprised. The person went to the floor, had a conversation, and then decided to bring back the result of that conversation, the pain points, to the middle manager. That was not well taken. It was, oh, but what is a doctor doing in a nursing unit? And then we know about this problem, it's been there for ages, and we know about these 2 people who are saying that if it continues like that, they're going to leave, but they've been saying that for a year, so it doesn't matter. And so it's transparency within the organization and allow each other to go and have a look how things are functioning. Leadership by walking, Gemba walk, we call it what we want, but it's a culture. So initially, it's not well perceived. But if we want to improve efficiency, to optimize what we do, we need to see innovation at not just technology. It is technology, but not just. It can be organizational innovation, and the technology needs to be seamless, almost invisible, to help people communicate with each other. Before we started this conversation, we had a discussion about how communication is key within patient safety. So technology, yes. Innovation, yes. But it needs to respond to pain points. What I sometimes say to the innovation people in our hospital, because we have innovation people, is that you need to go to where the magic happens. You need to go within this 24/7 function unit and see for yourself, as opposed as going to many startup meetings and then coming back and saying, I've seen this, it's cool, do we need that? No. Do it the other way around. What is it we need?
Yeah.
And then go and meet the startups.
Yeah.
I totally agree, because your diagnosis is correct, but it's all about change management as well. We are doing in my hospital at this very moment a very important lean project on an oncology ward. The starting point was nursing staff, physicians, overworked, too many patients, they couldn't handle it anymore. And they asked more and more and more staffing. We said, no, we will start with a lean project, we will analyze things and so on. The intermediate results show that by redesigning the process, there's more than staff enough. We even have a gain of, you're sitting all down, 20%. So with less resources, we can handle more patients.
And what did you do then? Or?
We really took the time to take the team on the path with our analyzers and so on, and we made the project their project.
Yeah.
They first have to see, they started with, Houston, we have a problem, and we said, okay, thank you for the problem, we'll go through it, and then step by step, little steps, all of a sudden, you see the switch from resistance to yes, we can.
Cooperation.
And so workforce is very scarce, okay, so we should care about where do we use them and for what, and how.
Yeah.
And that's why I'm a believer of lean in healthcare.
Yeah, Dr. de Mintenaren.
I also want to add a little point. The thing is also we have to let caregivers, staff, do what they are qualified for to do, and not to do things they're overqualified or underqualified. And I think that's also a mission to relieve the burden of burnout and things like that. So I think for that you need also a financing system that incentivizes the kind of the right work at the right place for the right person. And then I follow what Gilbert was saying. We need to adapt the financing model.
Yeah, let's have a look at the audience. Ladies and gentlemen, maybe you have practical examples that are already being used in your institution or hospital. So please feel free to share them with us. Yeah.
Well, good afternoon. I'm not working in a hospital, but I'm having a lot of members that are providing medical technologies. And so I think that there are plenty of excellent use cases that are not science fiction anymore. I think our host of the day, they made a proof in medication management where a lot of things in terms of regulation, traceability, security, etc. A lot of tasks for a lot of healthcare professionals that could be indeed being automated with a lot of better results also for healthcare professionals and patients. That's one thing. To quote indeed oncology, the same. I think the appealing things today are artificial intelligence, and today we are starting in process innovation with artificial intelligence, but also the patient could benefit so much. This morning in the newspaper, Professor Machiels, she mentioned that she could save upon 17 sessions of radiotherapy for patients, in breast cancer patients, due to the state-of-the-art new medical technologies that have been evolved, and that is not getting to the patient yet. The same applies for the Lancet publication, where today we have proved that the algorithm in breast cancer is so strong that 2 radiologists reading the image could be replaced by 1 radiologist, and so forth. The recent thing about telemonitoring in heart failure. How do we make sure that unnecessarily, due to telemonitoring, the patient is not getting into the hospital again, putting pressure on the healthcare professional? So I think we have plenty of examples. It always combines, ideally connecting the dots, it's product innovation, leveraged by my member companies. It's also process innovation, and often they're also at the bench, and it's data innovation. And ideally for new processes, we connect the three of them. It's not always an habit in the hospital to cope with, as you said, lean management, etc. And I think their co-creation, public-private co-creation, where we do have change management competences, etc., to help, to support also driving the change, will be important. But those for me are the technical aspects. And then, as you said, you have the human aspects. And what you were just explaining, it's about inspiring the people. And it's about leadership. And it's about making sure that there's a horizon for the people. Because if you go for process innovation and new care processes, it's going initially to ask more work. And they are already overwhelmed with all of this work. So for me, that human aspect in making sure that all of the good ideas, and there are plenty of them, are being put into practice is a human aspect. And that requires leadership. Where is our boat going to? And that's a problem for you, hospitals. I mean, we are talking about hospital reforms, but it's a complete black box. And so you don't know whether investing time, extra time, convincing your people to them will lead eventually towards an incentivized, and that's Dr. Bejani's indeed comment as well. Yeah, that's going to bring that magic alive. So for me, it's not about needing pilot cases anymore. Dr. de Mittenaar, we are talking also about services and technologies, home assistant, sleep apnea patients that could be diagnosed at home. We could treat 20,000 patients more at home, but the hospital is not incentivized of doing that. So I think, honestly, it's time to move the needle, but we will need to do it together.
Okay, thank you very much, Dr. de Mittenaar. You would like to add?
Maybe we need a magician to let the magic come. I just want to react to that. It's not only difficult for hospitals, it's difficult for our system because innovation is sometimes very disruptive for the processes we are all working in. And you have to change also every process. And a process is linked to people. So you have to get everybody into the same mindset, like you said. You have to give them a goal to change the system. And we're going to have to change everything, organization, but also financing, regulation, things like that. It's like somebody said before, it's a very complex system, and it's once you change one piece, you change the whole thing is moving. And that's sometimes very frightening for people into the system. So you have to, we need, like already Rudy said, leadership. We need a big leader who can incentivize the whole system to do the first. And we are taking steps. I think we are taking a lot of steps, smaller steps, bigger steps. We just need to go on and even accelerate certain steps. Because otherwise, we're always going to have a system that's going to be hard to get in for everything that's innovation. And that's sometimes a pity.
Mm-hmm.
I fully agree, but can I give a real-life example of what you just told the audience?
Please, yeah.
I think it's 1 or 2 years ago. We were busy with a oncology at home project. So everybody knows that, onco at home. You're wasting a lot of time talking. First of all, to your own physicians, then to the GPs, the general practitioners, then to the nursing, the first line nurses who are giving nursing care at home. And all of a sudden you see, okay, we have a commitment, everybody agrees that that's the process, and this care professional will do this, and this one will do something else, and you have an agreement. So we said, okay, now we will start a project, and we'll push certain tasks out of the hospital to the home care setting. and all of a sudden the project stops. And I was wondering why does it stop? And I got a letter signed by 4 nursing care organizations working in the home care system. And the letter said, we won't participate at your project unless you pay us €9 per patient we have to take blood.
All about money.
Yeah, but we tried for a year to get financing for the Model A, like they call it, where a nurse gets at home the day before your oncology treatment, so you have the results by the next morning, so you can start your chemotherapy immediately. But it's a hurdle that's huge.
It's so sad every time again. It's about money, and money is a driver to do the necessary societal changes we need.
Yeah.
I know. I think at the end here, everything's going to turn about money. Sadly, but
it's always the same thing.
It's always, yeah.
As for you, yeah. First, maybe here, Mr.
Yes, I'm happy you spoke about this example with the money. So money is really, financing is a real powerful tool to change the system. And I'm not the only one saying it, Porter is also saying it. You need to reorganize the system, but financing is a tool. But what's important, speaking about money, is where we really lack is emphasizing on I mean, really bringing people to trust our changing or transformation strategy, because they have to understand, and we need to do this, they have to understand they won't lose money. So if you have this nurse working at the hospital at some rate, if she can do the same job at the same rate, if it costs more, you should bring the patient back to the hospital. But the idea is people won't lose money, and everyone is afraid about losing money. Yeah. So that's also something sometimes we forget to tell. If you're doing like less overall activity in a hospital and doing more complicated surgeries, you will get more money for that. So the easiest cases would go to someone else who has a leaner organization and could do it with less money. Same with the GPs on the first line. They could do a lot of things with less money, but we need to give them that money.
Yeah, of course. The lady in the back maybe raised her hand also.
It's okay. Thank you. I work for a hospital federation, so this discussion is particularly interesting, of course, for us. Maybe just some comments, because first of all, I don't agree it should be all about money. I think the first goal of qualitative care is just making sure that patients are cured and that they are safe. So I think no matter what the money and the finance is, that should be the first purpose. And I strongly believe that all our members really try hard to achieve that every day. I do agree, on the other hand, that there is some issues compared to other countries. So we need to look into it. How does it come? And there are very interesting also quality systems, like the Green Cross method. That's an interesting system. It exists in Sweden, maybe also in other countries. It creates also a culture for talking about incidents, very low level with daily morning coffee breaks where doctors and nurses participate and talk to each other about what happened last week or tonight and how can we. So there are solutions to that. But I think, yes, I need to say something about the money, of course. And I think if you would, I try to financially stronger punish the people, you need to foresee a transition period, or otherwise you create a lot more stress than even already today is in the system. And I think it's also, Dr. Bejani mentioned this also. So trying to move the boat into the right direction, be careful what kind of steps you take. And I think the sector will, patients and caregivers will benefit from that. Thank you.
Okay. You would like to add something, Mr. Alonso?
Well, if it's permitted, I would like to ask a question, because
Yeah.
I'm looking around, I see a lot of experts, very smart people. I think we all know the data, and in 3 years the data won't be that different unless we do things. And the challenge I'm seeing in Belgium is that sometimes the little steps we do impact something else, so that something else needs to change also, that will impact something else, and that also needs a change somewhere else. So my question is, and maybe it's easy for me working in a company, I know at the end who the decider is, who will press the button, who needs to sign. But in Belgium, where does the power sit to change the whole model that we all know needs to change? I believe we all know what and how needs to change to get better, and we're all in this together. But who is the person, the role, or I don't know. I'm puzzled by that. Maybe that's the magician.
Yeah,
voilà.
he's here.
Yeah, he's here. Voilà.
We have in Belgium an activity-based reimbursement system. If we want to change a stated quality-based reimbursement system, we have to see how we explain all the people who are working in the existing world, how they will live in the next world. And the fact that if you have to measure the value in a new system, you have to explain to the doctor, to the hospitals, to my colleague that he will probably have to close 1/3 of his beds that he paid. It's 45,000 beds in Belgium. If you stop with 1/3 of the beds, it's 15 billion. 15 billion plus interest is 1 billion a year. He has to pay the bank. And then it's his main problem. His problem with personnel. He just says his personnel with lean organization, you have to align on efficiency. He diminish the cost of 20%. He changed the criteria. He doesn't say anymore we speak use volume. We just make for this pathology a line on quality. And those guys decide. But at a certain moment, my neighbor will say, hey, or the doctor will say, okay, we pay with value. Then you have to change all the system, and the fact is change management. It's not change the system. Value, okay, everybody agree for value. We'll decide. We need a government. We need a minister. The minister, he say, we change the model, and he communicate. We change his value-based healthcare system. And he says, as administration, I want to have a scenario to measure it. Probably it will take 5 years, and then implement it. But you doesn't measure and implement at the same time, or you put the poison pills in the system in the same time. Step per step, need a minister. The minister has to be convinced, and then decide to give instruction to administration, and everybody will follow.
Okay, thank you very much for your contribution. We shall see if it takes that way. So that brings us, ladies and gentlemen, to the third theme of our discussion. And we already talked about it a little bit, the efficiency of the system, because we heard that the use of technology could be a solution by automating certain tasks or processes. But we already heard that all investments in technology costs money. So, Dr. Spencer, do we need to put more money into the healthcare? And where could we find the money then for the necessary investments?
Even if I would wish for us to receive more, this is not going to happen.
No.
So we need to be smarter in the way we use it, but potentially to move from the fee-for-service system we have today to the value-based healthcare promoted by the Belgian Association of Hospital Managers, you will need investment. So money will have to come if we want the system to be transformed into something new. Efficiency, so the MAHA study showed that in 2023, 3/4 of hospitals were in deficit. Okay, we were lucky not to be. I'm not going to talk about 2024, but it's going to be worse. Okay, so that's a significant amount of hospitals. Most hospitals are in deficit. So something needs to change, for sure. We cannot be like this, because what it generates enormous tension on how are we going to survive up until next year. So although we do not want all conversation to be about money, we still need to talk about money, because if we manage to sort it out, then all the healthcare providers can play their best music. And that's quality. And that's quality. But we need to sort out the money issue. Efficiency is then a key objective of most hospitals. Looking at all your engines, the engines that are providing care, but that are also providing finance for the hospital, the operation theatre, how can you make it more efficient? And yes, technology is there, but technology is not going to help if you do not have the right human management in place. So hiring an OT manager, giving time to this OT manager to identify the pain points, and then turning towards startups and tech companies saying, okay, these are our pain points, how can you help us save it? And all this invisible technology that will help us there. So looking at outpatient clinic, because outpatient clinic for a hospital, it's not a big source of finance. If your orthopedic surgeon identifies a patient within the walls of your hospital, or he does that within his private practice, but a patient will be operated on in the hospital, that's what the hospital needs. So the outpatient clinic, how are we going to do that? Do we really want all the people to be full-time clinician within a hospital, or do we agree for these people to have their private practice? This is true for an orthopedic surgeon, this is true for a gynecologist, that we actually see that we would be better by allowing them to have more of a private practice, because the value added of the outpatient clinic is not great. Mm-hmm. Okay? Not that it isn't there, but it's not great. So it's looking at all the engines and how does these engines have a determinant on how you are financed, and then try to gain efficiency there. But it starts with humans. It starts with very good analysis of what the problems are, and then it's the collaboration with medtech. What we see is that all medtech companies are now looking to be more than medical device providers. We're welcoming that we are partners, that you're not just providing a piece of equipment, that you're also providing efficiency advice with it. These are the kind of relationship we're moving towards, and this is welcome.
Okay. Dr. De Mietenaren, do you agree?
I agree. I think we don't have to invest in tech just for the tech. We have to invest in integration and how we can find a good marriage between innovative technology and a new adaptive care system where we can integrate those solutions to help the system. But tech that doesn't add any value, we should not pay for that. Mm-hmm. I think that's the mission. And it's not an easy thing. It's difficult to say. The choice is huge. Which one do I choose? Which one do I don't choose? I think that's the challenge we have. But we also have to consider, if we accept technology, it should be in a care setting. And I think that's also a part of integrated care, not only between medical or care professionals, but also how do we integrate professionals, the care, and the tech into one smooth unit. Yeah.
Yeah. Yes.
If you look at not just efficiency within a hospital, but efficiency within a region, providing healthcare within a region, you look at the Brussels area. Within Brussels, there are currently 6 places where you can have 24/7 an emergency heart operation. 6 places. And that means that you have 6 teams on call, paid to be on call, of a cardiac surgeon, a cardiac anesthetist, a specialized nurse, and the team for the perfusion. And that's enormous. That's a waste of resources, a waste of money, and it's also a waste of people's quality of life. Because when in one hospital you only have 2 cardiac surgeons, they're on call every other day. Every other day they are on call. And that has a significant impact on what they do that evening, that night, that day. because they're available, they're close to their phone. We need better planning of the healthcare services within an area.
Yeah, regional. Okay.
Yeah, I just add, we already had some exercise in concentrations of care, and I think we still need a few more, but it's a very difficult issue, and I think it's also linked at our system, at how we finance care, how we finance our system. But I think some quality issues are linked to volumes, and there are a lot of places in our country where those volumes are not achieved and where we don't guarantee the quality based on that volume. And I think we do, our minister has a word for it, in Flemish it's called IKEA. Many caregivers and institutions are thinking, I can do everything on my own, and I think that's something that has to go. We have to not be competition, but we have to collaborate and organized care in regions, and based on what's the need and the need of the population. Because now it's very focused on volumes created because there's a financing behind it, and we have to consider more what does our population need on cardiac surgeons, for example, or cardiac expert centers. Do we need 6 in Brussels? You know, in Denmark there are 5 for the whole of Denmark. Denmark has 6.5 million people and a surface double hours, and they do it with 5. Here we got a region of Brussels, 1.2 million inhabitants, and much smaller, and there we have 6.
Let's be a little bit provocative here.
Yeah.
If you say, well, Sebastian, you say there are too many cardiac centers in Brussels, and you have one, why don't you close it? Well, I'm not going to close it, because if I close it, I have to stop all the very good interventional rhythmology that we do, all the AF, atrial fibrillation ablation that we do. We need to have cardiac surgery by law so that we can do it, and it will be then financed. So today, we are forced into continuing to provide heart surgery, and we will do it at the highest level of quality, because if we do it, we want to do it well.
Yeah, of course.
But today, there is no option for us to say, okay, we'll stop doing that.
But you can work together? Or
Yeah, but the thing is, this is linked at how our system is organized. So it's the same story again. Once you change one thing, you have to change the whole thing. And you have to change programmation, regulation, things like that.
Mr. Martens?
I think Sebastian has given a very real-life example of the problems we are facing when you want to try to work together with your opponents or your... There shouldn't be any opponents, but it's perceived like that. And I would like to come to your first question again. Will there be more money available to implement technology? No. I think there's, at the macro level, enough money into the system, but we should learn and change the system and try to use the money we have at a smart way. So, what I'm missing at this very moment, already several years, but also I don't see any change in the future. Where is that change plan at the systemic level? Where is that change plan? Where is the great vision of our politicians, of our administration, to go to a systemic transformation? But also, we all know Maslow. The first layer is make people safe, give them a roof above the head and something to eat and to drink. Safety first. Well, if you want a systemic transformation, and then you have to create a good change management and create a safe area. And then maybe Sebastian will lose or give away his cardiac surgery to another hospital. Why not? But you have first to create a safe environment, meaning what's the playground we are in. As soon as we reach some efficiency, saying we can do the same amount of care with less money, And if the government says, thank you, I will take it away.
Yeah.
Sorry, that's no safe environment. And that's what we need. And I'm happy that Stephanie is here from Zorgnet Icuro. I hope she will take the message to Margot and to all the other important persons in Belgium. But that's what we need.
Yeah.
It won't happen with a pull or push system. It won't happen with sanctioning people or organizations. It has to go through a change management process at a meta-systemic level approach, fully transformation, but it will take time.
Yeah.
10 years, 15, 20, whatever it takes. We can do it step by step, but we have to create a safe environment, and then every ship is going to leave the harbor. Mm-hmm. Everybody is going to go away from there. I'm having this budget now, and I'm doing that kind of care as of today, and you won't touch it.
Yeah.
We have to learn to lose that. We have to go further.
Okay, good. Yes, sir.
To continue heart failure, it's really interesting. You speak about the 5 centers in Brussels. There are 7. We have this in other regions. If we see 1 hospitals in the Flemish region who operate 850 hearts per year, and in other region there are 3 hospitals just operating the same volume, the 850. When you compare, we have 3 doctors, 3 surgeons in Antwerp, and we have 11 doctors in the other region. We have 3 times more nurses in the other region. If you decide, okay, I will invest for efficiency, this amount, there is only place for 1 of the 3 hospitals in the other, but you have to come with a global answer. Then you have to invest in innovation, just like we said before. You have to provide an ecosystem with a minimal size networks, but the network doesn't function because there's no financing, no interest. Then we say, okay, financing system, the bundle payment. Oh yes, but the bundle payment, you have to base it on a sort of good ecosystem. You have to measure it. And you want to measure it, you have all the data in one box. And we have all the data split it in all different ecosystems in Belgium. That first integrate all the data, measure it, integrate a financing with motivation, then we recreate the networks, and the finish with innovation is a circle. Then in the end, probably 2 for Brussels.
You would like to add something?
Is it the magician?
Yes, when I see all the ideas are great, all the diagnostic is correct, we all share these same ideas now. When I see all these small reforms coming, nomenclature, hospital financing, you say it could take like 15 years or 20 years. From really my point of view, we should do a huge reform really fast in a few years, within 3 or 4 years, on a real macro level, without going into details. How? We know what's the hospital's budget today. You can take apart from physicians' budget, which is fees of for working in hospitals. You can invest a little bit more, so no one loses money. You just put a little bit more for hospitals, a little bit more for doctors, and then you go for this bundle payment for hospitals. And you take an average price, which is the mean price in Belgium for cardiac surgery or for appendicitis or for any other surgeries. We have an idea about it. It's not, we can do it. And we didn't even do it for day case surgery. We went back to paid on justified day, journée justifiée for this. So we're really not going really forward, and we're always afraid of moving.
Yeah.
We know what's the budget for physicians. You know how much time it takes for some stuff. Some other stuff needs a bundle payment also. You can keep a fee for service for things that you cannot repeat, or you cannot cheat, or you cannot do several times. When you're operated, you're operated once. And once you do this, people would just adapt. So the big hospital would go because he has the teams, the knowledge, the machines, the personnel to go for really specific surgeries. You can, of course, put some rules about what should be done where, concentrating some kind of surgeries, cancer and complicated stuff. And the others would adapt. So you won't be doing small surgeries in huge hospitals, because in any lean system, it would cost you much more. But we could really do it in an easier way without going into this granularity where now you have to calculate how many needles you need for each kind of surgery. It will take us 100 times. And of course, I would be dead before. So the question is, who is going to take care of me in 10 years, 20 years?
Okay, good. Thank you very much for your contribution, ladies and gentlemen. I hear that it's time for action, in fact, that we need to start to make the changes. And that brings us, ladies and gentlemen, to the end of this interactive discussion. But before we close, we want to invite you to once again use your smartphones. So we have another QR code here. We have heard that we are all responsible to find solutions for the challenges in the healthcare system, and that we all can take small steps to move towards a more sustainable and resilient system. So my question now is, what are you planning to do differently in your institution as of tomorrow? So you can fill in a word or a sentence, and then we will create a nice word cloud. Value-based healthcare vision, plan a discussion. Value-based, it's little the same things that are coming back. Focus on lean, very inspiring. Yeah, the smart use of data. Thank you very much. As you can see, it forms a nice, wonderful cloud of words that can maybe help us to reform and to change the healthcare system in our country. So let's work together to help preserving our healthcare systems for the long term, in fact, and ensuring that both current and future generations, of course, will have access to safe, high-quality care while keeping also the health of our planet in mind. So, ladies and gentlemen, thank you very much for your contribution, for your participation, and also, dear panelists, thank you, of course, also Mr. Martens for replacing Ms. Candice de Wind, who is ill today and couldn't attend this debate. So thank you very much. Thank you, Dr. Spencer, and thank you, Dr. De Mietenare. And you, ladies and gentlemen, thank you for your attention and participation, but it's not finished yet. You are all invited at the front of this space to continue the discussions around refreshment. And we have here a little envelope. Jane will hand you over this paper. Then you have an easily access to the full report. You can scan the QR code and you can read the whole paper. So thank you once again for being with us. Have a nice afternoon and see you next time. Thank you very much.
Thank you. Thanks.